again, it is doing nothing to alleviate the immune genesis of this disease, right? So essentially, this is where this arm has been introduced. And in this arm, you're trying to do two things. One is to decrease antibody production and decrease the generation of antigen and antibody complexes that are depositing in the kidney to kick off the process. And also, you're trying to reduce glomerular inflammation. So, Nefecon was approved for this. It is approved for this. And for this, you can use Nefecon. You can use systemic glucocorticoids. You can use, now there are complement blockers that are approved. And we'll quickly go over some of these trials to kind of give you the idea. And there are other things that are probably applicable in certain um, populations. So mycophenolate mofetil shown to be effective in Chinese populations, not so much outside of that. Tonsillectomy shown to be effective in Japanese populations, not so much outside of that. And hydroxychloroquine again in the Asian populations decreases ongoing activity. So these are obviously considerations, but for us practicing in the United States, and I'm pretty certain that's translatable to our colleagues in Pakistan, you have to think in terms of altering the the clinical behavior of the disease, the immunological behavior of the disease. And the important thing is you have to think about these things simultaneously. You have to do them both. Now, the art of medicine and science meets here. If you get a 30-year-old who's fine, who's in your office because their creatinine is 1.6 and they've got a gram of protein in the urine, and you say, I'm going to put you on 5 different medicines, you'll never see them again. So, yeah, you sequence them in, but understand what you're trying to treat. So, if you're trying to treat an immune complex disease, you treat this and then start slapping this on over time because this is a longer process. This is at the tail end, and eventually you get them to the regimen. So sometimes when I'm treating these people with IgA nephropathy, it takes me a year to get to the final regimen that I need them to be on. So these are your magisteria of intervention: immune complex formation. So you want to decrease antibody production, you want to ameliorate inflammation, you want to mitigate the chronic damage and fibrosis, and you do general risk management. So what's their diabetes, hypertension, lipids, yada, yada, yada. So Nefigard, and I'm going to breeze through these studies because they are pretty much the same, tell you the same story, but I'm going to bring out some nuances. So Nefigard is Nefecon. Nefecon is locally released budesonide. Um, Formulations of this have been in vogue for treatment of inflammatory bowel disease for long years, but this one is specifically designed to release your steroid at the terminal ileum where the pair patches are, where most of this activity is happening. So it delivers it locally. The 16 milligram dose is delivered locally to the pars patches. Once it's absorbed, it undergoes an extensive first pass metabolism, and the systemic exposure of Nefigard is not more than about 6 to 8 milligrams of prednisone. Um, if you were using systemic corticosteroids to achieve a similar effect, you'd be dosing them 40 to 60 milligrams of prednisone a day. So that decreases the amount of steroid you're giving them, but it is a steroid. And so when you start somebody on Nefecon, you'll see in about 3 to 6 months a reduction in proteinuria, which continues. So then the drug was continued in this trial for 9 months, and then there was an observation period for 15 months that continued up to 2 years. And so keep your eyes on what's happening here. You see, everything's going down, the proteinuria is going down, proteinuria is going down. You stop drug here, then you see what's going on. Proteinuria is going up again. It's still significant here, it's still maintained, but it is beginning to go up. And this is something that I'll come back to in a second. Now, this is what happens to the GFR. The red is your GFR in the placebo arm. And the point I will make is, Jesus Christ, look at the loss of GFR over 2 years. So they have lost about 10, 12 mLs of 11 mLs of GFR. So you're losing about 5.5 mLs per minute per year of GFR. So if it's a 30-year-old man with a GFR of 50, and you put them on standard of care and nothing else because they had 800 milligrams of protein, what you're looking at here is that in about 5 years, you'd be starting talks about preparing them for renal replacement therapy. He'll be 35 or 38 at that time. So that's not good. When you put them on Nefecon, you see the GFR actually stabilizes during the course of treatment. They don't lose that much GFR. But once you stop treatment, they start losing GFR again. And this effect is titratable in people with less than a gram and a half of protein and more than a gram and a half of protein. So it protects both populations. And proof of concept is that when you put somebody on Nefecon, your your Gd-IgA levels in the blood drop. So the steroid is actually affecting the antibody production at the level of the gut. But look what happens once you stop treatment at 9 months. Almost immediately, your antibody levels start going back up. And so start filing off this information because this is how we have to think about this disease. This is not looking like a one and done disease, right? And the 9 months came out. It's the essential quip that what is a camel? It is a horse made out of committee. The 9 months came out because of bargaining with FDA. They wanted to do the trial for 6 months. The FDA wanted to do it in 12 months, so they did it for 9. But it turns out 9 months or even 12 months may not be enough. So just to focus back on the next avenue on which treatments are being developed, we talked about these different cytokines, and so the thought was that why should we try to knock out some cytokines, because this is also what is leading to this very high antibody production in the gut. And the antibody that we are worried about is the galactose deficient IgA, which is losing those O-glycosylated residues at the hinge region, right? And so sibeprenlimab was one of the first anti-APRIL antibodies. So we talked about BAFF and we talked about APRIL. So an anti-APRIL antibody was developed. So this treatment cohort, different dosage ranges. This is a phase 2 trial. Um, um, this treatment cohort received sibeprenlimab. I always trip over this. In a monthly infusion for 12 months, and you can see that it dropped the proteinuria from baseline to quite significant levels, more than a 50 to 60% drop. Once you stop treatment, especially in the lowest treatment tertile, you can start seeing a little bit of a release. You can see the same problem with Gd-IgA levels. In 3 months, the Gd-IgA levels come down. They stay down as you're treating. Once you stop treating at month 1 at 12, you can see the release, the antibody levels start going back up. And the GFR was preserved at month 12. So essentially, what you're looking at here is a proof of concept that anti-APRIL antibody is effective. The phase 3 trial of sibeprenlimab is called Visionary, and it's ongoing and it's about to be reported. And it looks like um, um, sibeprenlimab will go up for FDA approval later this year. Zika Kibart, I put this in just to plug our group's work. This is something we reported in Kidney International about a month ago or so. And this is again an anti-APRIL antibody, which has a sub-Q form now, which was given to patients. Again, same story. Your Ig levels go down, your proteinuria goes down, your GFR is maintained. And so many of these treatments um, um, are demonstrating the same concept. This is a different antibody. It is atacicept, or some people call it atacicept, and there's 3 different molecules with the same property. These are Bliss and April combined blocking antibodies. So they block both Bliss and April. So zigakibart and sibeprenlimab block the April and cytokine, whereas atacicept block both BAFF and April. And so again, you see when you compare it with placebo, your proteinuria goes down, EGFR is maintained. So everything that we want to see um, in um, in these patients. So we've now looked at steroids. We've looked at immune intervention through through either APRIL blockade or combined APRIL and and uh, um, BAFF or BLIS blockade. So in this atacicept, you can see that the Gd-IgA levels drop really, really fast, right? So this is probably, of all the different agents that I've seen, this is the fastest that you're dropping the Gd-IgA level, and this may have some relevance to how we think about how to treat this disorder in the future. So this type of intervention, and there's many others, I just don't have, the time. We will spend 2 hours just talking about the interventions that are being done on a trial basis right now to reduce antibodies. We're now using anti-CD38 molecules to knock out plasma cells, and the phase twos look very promising on those. So we're going to have this entire plethora of interventions available to us to reduce antibody generation. Now, what about inflammation? Obviously, steroids, Nefecon, we talked about, decreases glomerular inflammation as well as decreasing Gd-IgA production. But we know that once the antigen and antibody complex is formed and deposits, the HIT3 over there is setting up of inflammation, and a large part of setting up of that inflammation is through activation of the lectin and alternate pathways of complement. So obviously, complement blocking antibodies were of major, or not antibodies, small molecules and antibodies were of major interest in this disorder. So there are many different agents that are being evaluated. So narsoplimab, the phase 3 was discontinued. So phase 2 looked good. The phase 3 for this agent was stopped prematurely, so that's kind of out of the picture. But iptacopan, which is a factor B inhibitor on the alternate complement pathway side, this has been approved for IgA nephropathy and is available for use. And there are many others which are being developed. Most importantly is ravulizumab. So understand iptacopan and some of the other agents that are being developed are early alternate complement pathway blockers. Ravulizumab, which has been around forever, Ultomiris, is a terminal C5 inhibitor, and the phase twos for this look very, very strong as well. And we are actually part of a phase 3 trial on ravulizumab to treat IgA nephropathy. And the idea is to see if we can't shield the kidney from damage from the terminal complement pathway. Now, the thing is that when you do terminal complement blockade, you're hypothesizing that most of the disease activity is because of the terminal complement pathway and not because of proximal anaphylatoxins. So this hypothesis is true for hemolytic uremic syndrome, but untrue for C3 glomerulopathy. So we'll find out if this is more effective or this is more effective. There will never be a head-to-head, but we'll just have to compare data on this. So there's a lot of exciting stuff coming out, and there's some clinically available for complement blockade. And this is one of them. The trial is called Applause, published in the New England Journal of Medicine earlier this year. Again, same story. You got proteinuria change, significant drop with iptacopan because you're ameliorating the inflammation there and you're preserving GFR. So I'm sorry, this is again placebo versus iptacopan of protein creatinine ratio. So this has got preliminary approval for use in IgA nephropathy as well. Now we're going to switch gears a little bit, and we know that endothelins, and I'm not going to, because of time, going to the detail, but endothelins are bad actors. They cause vasoconstriction and endothelial damage. Yeah, yeah, magnify inflammation and fibrosis, lead to podocyte endothelial cell damage and mesangial damage, and lead to albuminuria, which is not only a marker but also a mediator of kidney disease, and have um, effects on the fluid and water retentions as well. So this trial is called PROTECT, which looked at an endothelium. So these are known as DRAs, dual endothelium and angiotensin receptor blocking molecules. So sparsentan has a moiety, which is an angiotensin receptor blocker in it, and has a moiety which is an endothelium receptor A blocker. So dual molecule versus ARB alone, which is irbesartan. So the perfect comparator. So patients were randomized into either receiving sparsentan, so the DIARA, or just an IRB, and it was superior to the IRB alone, not IRB, ARB alone, in reduction of proteinuria. It did protect the GFR, but note that even in the treatment group, this is the red line, you are looking at a GFR decline, albeit modestly better than placebo. So it's a classic protection agent. It does decrease your hard composite endpoints, dialysis, doubling of creatinine, or drop of GFR below 15, yada yada. So it does afford protection, but it is not altering your disease course. And finally, we're all familiar with the roles of SGLT2 inhibition. These are data that we have picked up. This is data from DAPA, CKD, but EMPA kidney also, same story. When you put people with IgA nephropathy on SGLT2 inhibition on top of RAS inhibition, you decrease hard endpoints. And so that is in addition to your um, protective effect from not just renal protective effect, but also you get your cardiovascular protection effects in these patients. So coming back to the guidelines, how should we approach this, right? The way to parse through this is to separate them into two different bunches. One is disease modifying therapy, which is what we should be thinking about. How can I change the course of this disease? And then the second is the protective racket. I see this all the time where people say, well, I've got this IgA nephropathy patient. I put this one on Filspari, which is sparsentan, and I put this one on Nefecon, and I put that one on Iptacopan. And I'm like, what is the thought process here? What are you trying to do, right? And so when you're putting somebody on a Diara, when you're putting somebody on ARB, when you're putting somebody on an SGLT2 inhibitor, you're just doing protection action. You're trying to protect the kidney. You're not doing anything to the disease itself. What you need to do with the disease is to change the immunological course. And so for now, you have Nefecon to decrease inflammation. You have iptacopan, but again, iptacopan is just going to decrease inflammation in the kidney. It is not going to change the course of the disease process. Very soon, you'll have other agents in here. You'll have anti-APRIL antibodies. You'll have combined BAFF and APRIL blockade. You will have anti-CD38 antibodies. So you'll have a list of interventions on this side as well. And you will have other complement blockers. There's already one approved in there as well. So then it will become much more interesting on how we choose to treat and how we choose to sell it to the patient that I've got you, I need to put you on 5 or 6 different medicines, and the patient's gonna say, you're crazy, I'm feeling fine, but you're looking at 10 years from now, 15 years from now, not now. But there are many different things that are still not clear. We know that you give somebody Nefecon, which is like steroids, the IgA gets better, but once you top the steroids, it gets worse. What's too early to treat? So we said 500 is not good, but what about 300? What about 200? What about somebody with just hematuria, no protein at all? Should we put them on lifelong therapy? So you have to kind of parse through that. You have to look at their risk and you have to draw a line somewhere. I think currently the line is fuzzy between 300 and 500, but that's opinion. 500 most people would agree with, 300 more fuzzy, but less than 300 unclear. But again, we're looking at these now because there's lead time bias. You're diagnosing them really, really early. And that may be the best time to change the course of the disease, but that entails very aggressive therapy with downsides and cost. So it's not clear there. What should be the duration of therapy? We're not sure because 9 months of Nefecon is not enough. And every trial has shown that once you stop intervening, the Gd-IgA levels start going back up. That's intuitive because we are controlling it. We are not eradicating antibody production. And in IgA, unlike in lupus, we may never be able to have a regulatory response strong enough to control it forever. So, are we looking at lifelong therapy? That's an open question. Are we looking at sequential therapy or combination regimens that you start with two different, like an anti inflammatory agent, maybe Nefecon, which decreases Gd-IgA, plus an immune agent, and then over a period of time get rid of the anti-inflammatory agent and maintain just on an anti-APRIL antibody or on a BAFF and APRIL blocker. Um, could that be the way things would look like in a few years? Or if you get something which is very effective, like I was showing you the atacicept data, where in 4 weeks the antibody levels drop significantly, maybe we can get away with monotherapy and use um, anti-inflammatory therapy only as needed. Are we looking at the need for cyclical therapy, that you complete a year, then give them a year of therapy, and then hit them again? Again, not tested. People are thinking about it, but we don't know the answer to that question either. And then finally, what to do with exacerbations. We've all heard about synpharyngitic hematuria. Why do you think that happens? You get a vaccination or you get a bug, your immune system revs up, you make more Gd-IgA, tic-tac-toe, 2 or 3 days later, you see blood in the urine. Now, that does mean that there's an angry response in the kidney. That does mean there's inflammation in the kidney. That's why you're seeing blood in the urine, right? Macroscopic hematuria. So, should we be treating these patients with steroids? Some clinicians do. Again, very little data. That's a practice style. So, it is a very exciting time to be an IgA nephropathy doctor these days. Many different options available, many more coming up. There's more we can do for these patients. There needs to be a complete recalibration of the way we think about this disorder. And we need to get away from the rut of, yeah, I got them on an ACE inhibitor, their proteinuria is below XYZ, and therefore my job is done. Your job is not done. You've still left them with risk. The only thing is, it'll happen 15 years from now, and there are good chances that you would have retired by then, but your patient would be left with the specter of renal replacement therapy. And the other advice I have for everybody is, this is where the art of medicine also meets the science of medicine. If seeing somebody in clinic who's 30 years old with a GFR of 55, and if you say, I'm going to put you on 10 medicines, they're going to run away. They're not going to do anything because they don't feel bad. But you do what is important first and then lead up with what needs to happen later as well. So sequentially, and like I said, sometimes it takes me 6 months, 9 months to get them on the regimen I need them to be at. But eventually, once you've built that trust, once you build that linear care, once they listen to you, you'd be able to. So I will stop here and invite any questions. Would be happy to take them, and thank you for everybody's attention.
Thank you, Dr. Awad. First of all, I really want to thank you for an excellent presentation and summary of really, this is a paradigm shift, a disease which was once really forgotten in terms of, you don't pay attention too much because you don't have much to treat with. So people were even questioning biopsy or not to biopsy, when to rebiopsy, So now the new paradigm is it will become uh, a minimum three drug condition. I can imagine, lupus is a three drug condition, ANCA is almost a three drug condition. This will become a multi drug condition as well to treat. And I'm sure, there is a new interest into management, and also we are seeing more and more in terms of diagnosis. So uh, I believe I may ask you a question or two, which you can answer after I'll invite Dr. Masood for his comments. I know there are a lot of myths about IgA. One, even people want to measure the IgA level, which is um, maybe I'll take your feedback on that. And I think the people are still, sometimes we hear questioning if you biopsy or not to biopsy in how early or how later. So I think some of the comments on that, and it looks like that in the treatment phase we are still struggling with prior auths, which is a common thing. I have a couple of patients. I'm struggling with budesonide, so I put patient on prednisone, and I was struggling with the atrasentan, so I'm using the ARBs for my patient. Although slow respond, but some response. So thank you. Dr. Masood, you want to add something, and then we'll open the house to everyone. And please use the raise hand function so we go one by one.
No, thank you, Irfan. It was a wonderful talk as ever, yeah, as you always do that. And I want to add anything other than what Farooq said, because I don't want to, want to spare more time for questions. I'm sure there will be a lot of. I have a couple of questions, but I will let audience to ask question before I do.
So while we wait for any questions, Omar asked a couple of questions which I think are very pertinent. So when to biopsy? So the sooner the better, right? So this is a diagnosis that cannot be made without a biopsy, and people should be biopsied. So if you got somebody in your clinic who's got who's 30 years old, who's got blood and protein in the urine, they need to be biopsied. I mean, there's no shortcut to that. Cannot make this diagnosis without a biopsy, and um, and this culture is changing. United States. It's not unusual for me to see these patients 2 years later. From the first time they presented, they went to the ER with something. Somebody told them, "Oh, you got protein and blood in your urine. You got a UTI." So they get an antibiotic in the ER. Then they go to the PCP. They say, "Well, your UTI is not better." They treat it again, and then they send them to a urologist who does his thing and does a cystoscopy and says there's nothing wrong with you there. And then eventually they find their way, not because even if they had just blood, eventually initially now they have blood and protein, and they find their way to a nephrologist, and then finally they biopsy them and make the diagnosis. And there's literature in the United States that there's a lag between initial presentation and diagnosis of 1 to 2 years, which is regrettable in today's time, but this is the nature of the beast. And so when you get them, don't don't put them on an ACE inhibitor and wait 6 months to see if the proteinuria goes away before you biopsy them so that you have a diagnosis. That's the first point. The second thing is about Gd-IgA levels. Now, Gd-IgA levels are very difficult to do. They're finicky tests. And so every trial has done Gd-IgA levels through their in-house mechanisms. When you're doing a trial, you send blood off every week, 2 weeks, 4 weeks, whatever the protocol is. And so they do these tests in-house. None of those have been translated into free commercially standing platforms. So Gd-IgA levels are not available. Unfortunately, there's no other biomarker available for IgA as well. And so you're left with protein and blood in the urine. And IgA is one of those disorders where hematuria actually correlates with outcomes. Proteinuria correlates with outcomes. GFR correlates with outcomes. So you've got that. And then there's a question of rebiopsy. Now, I went through the Oxford classification rather quickly, and I probably should have made this point that I sometimes see people making treatment choices based on the MEST um, um, based on the MEST score, and the the fallacy in that is that the MEST score or the MEST C score after 2016 is not calibrated, is not validated. So the Valiga group, which validates the MEST score, has only validated it for long-term outcomes. And when you look at agreeability between pathologists about what the MEST score is, the highest agreeability is on the T side, the fibrosis side. So they look at, say, yeah, 50% fibrosis. That's what they agree on. M1s, M2s, C1s, C2s, and E1s, E0s, they don't agree with each other. And so a lot of times, when I'm enrolling patients with trials, the trial window is an IgA biopsy, 10 years, anytime between now and 10 years ago, right? That's the usual window because we're trying to get patients in. So the idea is if you look at high MES score, high inflammatory activity on the MES score and all that, you can maybe intuitively get some information out of it, but technically the histopathology has um, not been calibrated to predict what kind of treatment would work. And so, what kind of treatment works is we know what's driving the disease, which is IgA production and generation of antigen antibody complexes, and then complement activation and fibrosis and inflammation and fibrosis and damage. So we want to break that cycle. Eventually, hopefully, we'll have better um, markers which would help us delineate between phenotypes that are less likely to progress versus phenotypes that are likely to progress. But right now, the only yardsticks we have are blood and protein and GFR.
Okay, Irfan. So as we said that you said the complement activation has a significant role in pathogenesis of IgA nephropathy. And talking about biomarkers, how come we don't have reduced C3 in particularly here, and as compared to other diseases like lupus and post-infectious, when you have complement activity, but we see and follow low complement level in those diseases?
No, that's an astute observation. It is no doubt a complement mediated disease. But you drop systemic complement levels, so your C3, C4 in the blood will drop if complement is being activated in fluid phase. So complement can be activated in fluid phase inside the blood vessels. So in lupus, in Sjogren's syndrome, in cryoglobulinemia, in infective endocarditis, um, your complement is being activated inside the circulation, and so the massive consumption, and you drop your C3 and C4. In IgA, it is local tissue activation of complement. So your systemic complement levels don't go down. However, if you do drop your C3 in IgA, and there are times when you do that, that actually tells you that this is a very high risk IgA phenotype, and that there's a lot of damage going on. But you don't classically see systemic hypocomplementemia in IgA because the phase of activation of complement is different.
Thanks. Umar, there's a question. You want to read that? Or?
Yeah, I think there are some questions in the chat. So one is the role of rituximab in IgAN. Literature is not convincing, and so that is one. Second was the role of GLP-1 RAs, especially in the slowing the progression arm. Do we have any data on that?
So to take the first one, rituximab, yes, and again, you have to kind of understand what we are trying to treat. So the traditional paradigms of B cell mediated disease, slightly different for IgA, since most of the immune activation is in the mucosal immune system, and it is T cell dependent as well as T cell independent. Rituximab is not very effective because the amount of tissue progenitor cell depletion with rituximab is low. It's more, circulation and lymphocytes. So there are phenotypes of IgA, the rapidly progressive crescentic types of IgA, which may be a different disorder, which may not be your classic IgA, but may have the antibody may have more ANCA-like systemic antibody production features. The rituximab paradigm may work over there, but it doesn't work in IgA per se. But what we are trying to do is to do plasma cell depletion with CD38s. So that's that. And I'm sorry, what was the other part of the question?
I think the GLP-1 RA.
Yeah, I got nothing for or against that. The IgA literature, that's I think transposed from CKD paradigms. If you've got CKD, especially if they're obese, they want to lose weight, why not? It's not going to change the course of the disease otherwise.
Two more questions. One is about any role for genetic testing, or if we have any discovery on that side. And then if you want to comment on this, and then I'll ask the second question. It's about recurrent IgA.
Yeah. So there's clearly genetic predispositions to IgA. So I mean, I said that, this is where the gene meets the environment type paradigm, where you've got some genetic predisposition to make the Gd-IgAs, and then your environment, especially your microbiome, is such that it kind of gives it a boost. But we are not ready to use any of these mutations in prime clinical care at this time. So you can't really order the test to figure out what to do at this time. But there are genes which confer high risk for progression of IgA, and there are genes that confer risk of certain types. And so those libraries are being built, and eventually we'll be able to have some of those markers like APOL gene 1 in the United States. We have that marker that this person is not going to do well. So if you've got a lupus patient who's got APOL1 gene, actually an IgA patient who's got APOL gene mutation, they're not going to do well because generally they don't respond well to renal stress. And so we will have some markers that will tell us this is a high risk phenotype, but that risk stratification is in its real infancy at this time. But that is where we need to get to, particular genotype, particular phenotype, and what is their perceived risk so that we can correctly adjudicate what degree of therapy is required in that particular patient. We don't have that yet.
So another very interesting question, and I probably will add a twist to that question as well. So the question is, are these new drugs only tried in primary IgA? What about recurrent IgA? So the recurrent IgA, please elaborate when you answer. Is this like flare? Because once they have IgA, the underlying pathology, I can imagine, will remain in IgA. I was involved in one of the trials, not the atacicept, but telitacicept, and I believe their inclusion criteria had, really the primary diagnosis long time ago, but the current presence of proteinuria and hematuria was their one of the main inclusion criteria for the disease activity. So, so I think that drug was actually applied in a patient who had primary diagnosis long time ago, but then patient was still having activity, and actually that drug helped. So how do you see this concept between primary or the initial, diagnosis, and then recurrent as flares versus, stable activity?
So when you say recurrent, are you, I just want to be clear before I start answering the question. Are you saying recurrent in the allograft or recurrence in the same person?
Yeah, so that's I don't know. Hina asked this question, so maybe they can Hina can elaborate if this is, oh, it's a post-transplant. Okay, so that makes sense now. Yep, we have some patients who we have IgA in the transplant as well. So
Yeah, so essentially, a fairly high number of people with IgA nephropathy have recurrence in the allograft, but it depends on how you define it. So without going into nuance of what that means, let's suppose you've got somebody with a well-defined recurrence of IgA. They've got proteinuria, they've got hematuria. So a couple of points I would like to make, and that is, you know, the risk remains with the patient because they're still making Gd-IgAs. And like I said, that there are some homing mechanisms in the kidney, right? CD71 and soluble 89 and so on and so forth that home those antigen antibody complexes to the kidney. That's why sometimes you don't get recurrence because either the immunosuppression that we're using for kidney transplantation knocks out the immune response and you stop making your G, or you don't have the correct homing mechanism in the kidney and the kidney is spared and you don't recur. But about 40 to 50% of people with IgA who are transplanted have some form of recurrence, but 10 to 15% are severe. So let's suppose you've got somebody there. What I have started doing, and this is with the luxury of practicing medicine in the United States where we have more resources, what I've started doing is, I've transformed. I was reactive, where if I saw protein in blood and I biopsied and I saw some mesangial deposits and IgA in the mesangium, I would switch them to Tarpeo from prednisone. Now what I do is at the end of the first month, as I'm tapering my steroids, I just switch them to Tarpeo. And um, this is anecdotal. There's no data behind it, so don't think that this is coming out of any trial because all kidney transplant patients are excluded from trials. And so that's what I do. If there is overwhelming activity inside the kidney, you can put them on complement blocking drugs on top as well, to protect the kidney. And there's nothing stopping you from adjusting immunosuppression and using um, B cell modulation. Something like atacicept in a transplant patient. But you have to be careful. Atacicept was tried in lupus when patients were on steroids and MMF, and there was a host of infectious complications. So that, got people into trouble. So you have to be mindful that each one of these things, they keep adding on. And so you have to modulate immunosuppression. So if you're doing it off label, you have to be very cautious and you have to do it very, very thoughtfully. But treatment, um, treatment is anecdotal, and different people will tell you different things because this is mostly opinion driven. To answer your question, Umar, that somebody was diagnosed with IgA nephropathy 10 years ago, right? And now they're in your office and they've got 2 grams of protein and blood in the urine. Yeah, that's the phenotype that we missed 10 years ago. They should have been treated 10 years ago. We probably would have bent their course. Now they've got a GFR of 50 and they've got blood and protein in the urine. You got to treat them, right? So you've got to put them on treatment now.
Yeah. So another question from Dr. Aziz Rahman. And before I pose the question to you, let me share one of my patients. So I think there was an observation in the transplant world that donors who were getting protocol biopsies, there was IgA staining in those donors when those kidneys were transplanted in the new host. So the
Goes away.
recipient, when they did protocol biopsies in future, and this was a matter of few months, that staining actually went away. So general population, undiagnosed, non-active IgA in donors. This was just based on the staining, but when in recipient, I think you remember that it went away. Now I have an interesting patient.
I would just interject
He's-
one little thing. One thing that we have to get away from is to say non-active IgA.
Sorry.
Yeah, because that's what we call it non-active, but it may not be
Mhm.
non-active, right? But yeah, your point is very well taken, and it goes to the fact that it's an immunologically driven disease. Once you take that kidney out from that milieu where there's no more Gd-IgA or other antibodies, then it goes away. Sorry to interrupt, but I just wanted to make that point that non-active may not be an accurate term. So
I appreciate that. I think those are some of the, classic teaching and classic learning. I think this is the paradigm that we have to kind of change in our mind as well. So I have a patient. So uh, the son gave kidney to father, and father, so the recipient developed IgA nephropathy de novo in the transplanted kidney because we had biopsy on the recipient before the transplant. And then son never got IgA. So we had basically no evidence of any activity on the in that person, but father, of course, developed IgA in the transplanted kidney. So this was like one of the very rare kind of it can happen, but so we reported it. So this is the question for a general question about recurrent rate after transplant. I think you answered this question, but more specific question is like, what's the role of living related kidney? Should you accept if a recipient, a future recipient or potential recipient, they have IgA as their primary diagnosis, should they receive living donor or not, or should they only be for deceased donor? And I think this is a relevant question because this gets asked a lot.
Well, the question is that should they receive from relatives, the family, right?
the answer is yes,
related. Yep.
yes, and yes. Find them a donor. If it's a relative, I don't care. Find them a donor, transplant them. The outcomes of staying on dialysis far trump the issues that would happen 15 years from recurrent IgA. So you need to transplant them. So the only time IgA crashes and burns is if you transplant somebody who's had rapidly progressive renal failure with crescentic IgA, and you transplant them very, very quickly. So those are the patients you want to let them cool their heels a little bit, get on top of the disease again. That's a different disease phenotype. That's not your typical IgA. Most typical IgA. So now the example that you just presented, it is, and I don't know the details of your case, Umar, but a lot of times people come in with cause of chronic kidney disease, right? They've got hypertension or something, and they've got scarred down kidneys because of chronic glomerulonephritis because of IgA. And once you transplant them, they have a recurrence, and that's how you diagnose that. Oh, the primary disease must have been IgA. It is not unthinkable that somebody would develop late onset de novo IgA as well. So I mean, it can happen at any time, but it can happen late as well.
Okay, so I have a question.
Please
If anybody else waiting for his or her question, so
I think we have gone through chat and I don't see any hand raised, so please go ahead.
I was just looking. Very quick question which I can answer. Somebody answered how to dose Nefecon.
Oh,
So
yes, I missed that. Sorry.
15 milligrams a day. And when you're planning to stop it, generally the trial was for 9 months, but I've got people on Nefecon for 2 years now. And again, that's anecdotal. My practice, so I'm not saying that there's data for that. There are trials. We are participating in those where Nefecon is continued for longer periods of time because we're still trying to range what is the right duration of therapy, right? But if you choose to stop it, the suggestion is to decrease the dose to 8 milligrams for 2 weeks and then stop it so that if there's been some excess suppression, you can taper it off. So 16 milligrams a day, cut it down to 8, 2 weeks later, stop. Aves, you had a question, my friend.
Yeah, what's your experience with Nefecon? I mean, I have patients who I put on Nefecon. Luckily, they are not diabetic or obese, but I have a couple of patients who are obese and they have, high risk for steroid-induced toxicity. Luckily, at least all three of them, they don't have like active going on. I mean, they're pretty controlled on the, that medications like ACE inhibitor or SGLT2. What is your experience? I mean, how much like a patient is like a obese, like a 250 or 300, pound weight, and would you put on that, on Nefcon on that, or you would rather not?
So
I know systemic steroid probably would not you look for, but these are not systemic steroids.
but they're still steroids. So your point is very well taken. And I've had patients who've gained weight more than the 2.2 kilogram that the trial touts. I've had patients who've moved their A1C up or become diabetic because they were kind of on the cusp anyways, and they precipitate their diabetes. So these are all real concerns. So if you ask me today, this is the only game in town which would decrease your IgA levels. If you ask me in December, I'd probably use an anti-APRIL antibody because by that time we'll have the first anti-APRIL antibody approved. So I think this is where having those choices comes in handy, right? If you've got 3 or 4 different choices, you can then tailor the immunologic therapy to the phenotype of the patient and adjust it to their risk. So if I had the choice, I would never use a steroid on anybody, right? In any dose. I mean, those are horrible medicines, and I don't like them. But that's the only drug we have right now, even in the United States. But once they get approved, the other agents get approved. Once you have your anti-APRIL antibody or your combined BAFF-APRIL antibody approved, I would probably, in a patient like that, use that. And if I need to use an anti-inflammatory agent along with it, because there's a lot of blood and protein in the urine and you want to protect the kidney, you would want to use an iptacopan along with an anti-APRIL or BAFF-APRIL antibody to protect the kidney while you get on top of the acute inflammatory phase.
So other question I have, like CellCept or mycophenolate has been used in Chinese trial and Chinese population. How about Chinese population here in US? And we all have patients from, Chinese descent. Any effectiveness on that?
Yep, it works. So if you've got somebody of Chinese, Taiwanese, Korean extraction, I use MMF.
I've done the same, and it worked on one of my patients. So, but the experience is small. There's one more question, and I think it's a long one. So, Dr. Aga, you want to read together then? And then maybe this will be okay.
Yeah, unfortunately, I don't know the data on MMF effectiveness on a South Asian population. It's been validated only in a in a Chinese population actually, and we extrapolate that Korean, Taiwanese, Chinese populations, Japanese would probably respond to it. Novel agents are not, even Tarpeyo is not available in Pakistan right now. Nefecon, budesonide.
Doesn't look like from the discussion or questions up. Maybe do we know? Does anybody can comment if budesonide is available in Pakistan or not?
Yeah, it's people are
It's
saying
not available.
I think somebody should work on that. There are preparations of enterically released budesonide that are being used for inflammatory bowel disease, but unfortunately, the ones that are designed for Crohn's disease release the steroid throughout the gut, and so it's not concentrated on the terminal ileum, so may not have the desired pharmacodynamic effect. And the ones designed for ulcerative colitis actually start releasing the drug when the capsule reaches the colon, so it kind of misses the Peyer's patches. So there is some data to suggest that of the enterically released steroid preparations, Nefecon probably is the most optimal. But in a pinch, you could probably use in a slightly higher dose. And this is again, I shouldn't be doing this. I'm just musing with you to see what you can do. You could probably use one of the other enterically released budesonide preparations in a slightly higher dose to see if that would help your patient.
And one more question I have. So Finerenone, I know it's approved only for diabetic nephropathy. But again, there's no harm in, if approved, in other medication? I mean, the condition like membranous or even IgA. Have you used it?
I have not used finerenone as a antiproteinuric agent very commonly. I use it sometimes, but like you said, there's no harm in doing that, and we should not be hesitant in adding it on. But I would go ARB or ACE plus.
Obviously, in addition to that, so I have used like 2 patients with membranous, and actually it made a significant difference. And I was surprised that they got approved.
Yeah, but again, when you're using it for membranous, same thought process, right? Proteinuria reduction and kidney protection is important, and that's all these agents are going to do. Your ARBs and your SGLT2s and your MRAs, all they're going to do is to reduce proteinuria by decreasing the glomerular hypertrophy.
Actually, it buy you some time to see whether they go to remission or not. Actually, both of these patients I'm talking about, they went into remission. Okay,
That's
and
sometimes goes into remission on its own, right? So 30%, 35% of membranous undergoes spontaneous remission. So it's not causal, like at all. But what the point I'm trying to make is if you got membranous with 4 or 5 or 6 grams of protein, then you can't put them on these antiproteinuric agents and then say, okay, mission accomplished. You still have to treat the disease. And on its merit, sometimes we choose not to do immunosuppression for membranous, and this might be one of those situations where the proteinuria receded itself and went into complete remission. Hallelujah. But if they remained with 4.5, 5 grams of protein and their PLA2R was 150, you obviously have to treat it.
Looks like we depleted all the questions and asked you a lot of twisted questions too. So thank you thank you always for answering those questions with really supported by the evidence and making sure that we stick to common sense as well. Appreciate all that.
It was a pleasure.
great. Okay, should we call it a day?
At night in Pakistan, I think it's
In
pretty late.
Pakistan. It's pretty late. So thank you everyone for joining and staying with us. We still have, a decent participation. So we'll see each other next month. I think towards the end of July, we have the session on lupus. So looking forward to
very
that.
exciting.
Thank you.
I'm sure we're going to learn a lot from that. Thank you, Irfan. Really appreciate all your teaching and